morning to you all. I would personally thank all the press professionals to be here. As a matter of fact, you are our voice in the general population, so we are working hard, but without you, sometimes our work will never get out of the Congress, so thank you for being here. I'm going to start just saying that so far the day has been busy. At 7 o'clock we had the Women on Thoracic Oncology networking event where all the researchers and oncologists just put together their knowledge and they change their ideas and how they just do their research lives and try to balance with their family lives. Then we had the General Assembly. Important to have this more democratic society. We're in that direction. And now we had the plenary session. The plenary session, I want to highlight some of the communications that were presented. The first one is an example of surgical surveillance for nursing. So it's another example of giving power to the role of nurses. And we have Jennifer at the end of the table. She will just comment afterwards more in detail this role, but how they can implement their task in the surgery and control and avoid unnecessary visits. Then we had a very important talk on immunotherapy, how this has been changing from very late stage. Now it's in the neoadjuvant or adjuvant therapy, and how it's really changing and how maybe it can be a chronic disease. Now it's being used like this. There are 4 international phase 3 trials with 4 different molecules. There's Pembro, Dubra, Nivo, and Atezo. There are these long-term follow-up trials, so it's maybe gonna change a little bit our perception of the disease because they're gonna control once patients have been operated. Then we had another talk about the role of IASLC on the different challenges the society has. One is tobacco control, and I want to highlight that there was a declaration on tobacco control that just stresses that all cancer had to be checked and try to avoid smoking and try to stop it, and how this smoking has to be implemented also in the clinical trials. Also, there's another point, is how screening is maybe already known as a tool that avoids death, but how it's very low implemented. Now we know that in the United States it's less than 4%, so what the IASLC are going or pretend to do is to give positive message so that people go and get screened. And there's another point in this talk about molecular testing. It's a survey that has promoted IASLC, and it's just comes to the result that only 60% of the centers do molecular testing, and probably the 3 most very important barriers are cost, quality, and access to molecular testings. For those problems, the IASLC has launched the Long Ambition Alliance. So it's an education program with aim to control of these problems. Finally, we had a very interesting historical perspective talk about the parallelism between lung cancer and tuberculosis, how tuberculosis went a long way until it was controlled, and how we, from lung cancer, are just going more or less in the same way. So we envision that one day we're going to have a better and absolute control over the disease. Now I'm going to just give to the speaker that will just give you some summary of his results, and then another colleague, and then we go for questions. We're going to have to take place. Yeah.
So thank you, and my name is Martin Rake. It's my pleasure to share with you a sneak preview on the Keynote 24 results. You will see the full results in 45 hours, and As you mentioned, immunotherapy has changed completely management of lung cancer. So we really are changing lung cancer to a chronic disease with a good quality of life. And I think this is one of the good examples. So these are my disclosures. And what we have seen is that an immunotherapy with pembrolizumab is a monotherapy opportunity for first-line treatment in patients with PD-L1 expression, as well as in combination with chemotherapy in patients regardless of the PD-L1 expression. And the superiority of pembrolizumab compared to chemotherapy has been shown in a prospective randomized trial, the KEYNOTE-24, comparing pembrolizumab to chemotherapy in untreated patients with advanced non-small cell lung cancer without oncogenic alterations with a high PD-L1 expression on the tumor cells. And what we have seen has been a significant improvement in progression-free survival, overall survival, and we are talking about a hazard ratio of 0.6 as well as response. And what we are sharing here is an update. So we have a longer follow-up. We are talking about the 3-year survival update, and we are talking about the group of patients who received already the 2 years of pembrolizumab as a first-line therapy opportunity. And these are the survival data. So what we do observe here is a consistent benefit in survival, even with a longer follow-up. So we are seeing a prolongation of the median overall survival from 14.2 up to 26.3, corresponding to a hazard ratio of 0.65. And we do see an improvement of the 3-year overall survival rates from 24.9 up to 43.7%. And you can see the plateau of the overall survival curves. There's really some patients who have this disease as a chronic disease induced by immunotherapy. While treatment duration has been longer for pembrolizumab compared to chemotherapy, 8 months compared to 3.5 months, and despite the longer treatment duration, tolerability was in favor of the immunomonotherapy with a lower frequency of treatment-related adverse events, and in particular, relevant treatment-related adverse events, grade 3 to 5 treatment-related adverse events. Well, what about immune-mediated adverse events? And this is the question, what are we inducing when we treat the patients for 2 years? And interestingly, we haven't seen a lot of changes in the frequency of immune-mediated adverse events. It's still the same percentage. 34 patients do have immune-mediated adverse events. Most of them have mild to moderate immune-mediated adverse events, and very few have relevant immune-mediated adverse events. And when we look on the picture, what kinds of immune-mediated adverse events do we see? It's the same picture. So we do see changes in the thyroid metabolism, hyper and hypothyroidism. We can treat this. We do see some patients with infusion reactions, GI events, or pulmonary toxicities. This is a look on those patients who received the 2 years of pembrolizumab. These have been 38 patients, and in principle, the time to response was consistent 2 months. But when you look on the individual patients, we do see that there are some individual changes in the reaction to pembrolizumab. We even had 2 patients who qualified for a complete remission after 2 years of treatment with pembrolizumab. The duration of response was very, very high. 81% of the patients who had received 2 years of pembrolizumab had a duration of response of at least 2 years. And at data cutoff, 71% of these patients still have a stable disease without need for any additional treatment. And one additional information which is in favor of the patient, after 2 years of treatment with pembrolizumab, there was the opportunity for a second course of pembrolizumab if the patient progressed. And this is work in progress. Currently, we have data from 10 patients, but what we do see is a clinical activity even after re-exposition of pembrolizumab. So we do see a stabilization or response to the disease in 70% of the patients, and 50% of the patients are still ongoing. So in summary, we are confirming the efficacy of pembrolizumab compared to platinum-based chemotherapy in this long-term analysis with a consistent benefit in overall survival. And we do see this benefit despite a crossover of 65%. tolerability was in favor of pembrolizumab, even with a longer treatment period. And when we look on those patients who received the 2 years of pembrolizumab, there has really been a durable clinical benefit, and we have the first signs of efficacy of a re-exposition to pembrolizumab at time of progression. Thank you.
Okay. Thank you so much, Dr. Reck. Now we turn to Dr. Capuzzo, and then we have questions, and then we continue with the other speakers.
So thank you. It's really a great opportunity to present you the data from the Empower 131 trial. This is a very relevant trial because it was conducted in a group of patients for which we need additional therapies, that are patients with squamous histology. So this is just my disclosure. Very briefly, I present you what is the design of this trial. This is a phase 3 trial that was conducted in more than 1,000 patients with metastatic squamous non-small cell lung cancer in good clinical condition. These patients were included in the study irrespective of PD-L1 expression, and they were randomized to 3 different treatments. The control arm was chemotherapy alone, and chemotherapy consisted in the association of carboplatin and nab-paclitaxel. And then we had 2 experimental arms. One was the same chemotherapy regimen plus atezolizumab, and arm A was the combination of carboplatin, paclitaxel again, and atezolizumab. In this study, we had 2 independent co-primary endpoints. One was progression-free survival, and the data for progression-free survival were already presented in a previous meeting, and we know that this trial is positive because we have a significant prolongation in progression-free survival for patients receiving atezolizumab versus those patients receiving chemotherapy alone. And here at this meeting, I'll present the data on overall survival. So when we look at the overall population of patients, there is no difference in overall survival between chemotherapy alone and chemotherapy plus atezolizumab. But even if the survival was not improved in the intent to treat population, when we look specifically to the group of patients with high levels of PD-L1 expression, there is a clinically meaningful improvement in overall survival. The median overall survival was 23 months for patients receiving atezolizumab plus chemotherapy, and 10 months for patients receiving chemotherapy alone. The hazard ratio was 0.48, meaning that in this specific subgroup of patients, we had a reduction in the risk of death that was more than 50%. So based on this data, we concluded the Empower 131 trial is certainly a positive trial. We had a PFS improvement, significant PFS improvement, that is the independent co-primary endpoint, with a meaningful survival difference in the group of patients PD-L1 strongly positive. So this data clearly suggests that these patients specifically may benefit from the combination of chemotherapy and atezolizumab. Thank you.
Thank you, Dr. Capuzzo. Now both papers are open for your questions, doubts, or comments. Please, over there.
Martin. Martin, last presentation, one quick question. How many of them who failed pembro mono, when they failed, switched over to the combination pem plus pem chemo?
So
And
we,
how
we
did
do
they
not have a crossover to combination of chemotherapy plus pembrolizumab.
Yeah.
So this was not permitted per protocol. The only crossover was from chemotherapy to pembrolizumab. So we have some patients who received different immunotherapies out of protocol, but the majority received chemotherapies.
Alone.
And currently, pardon?
Chemo alone, without
Chemotherapy alone, and this have been 42% so far at this data cutoff.
Okay, got it, thanks.
Over there.
thank you. Pam Harrison, Medscape. Well, you say patients receive 2 years of treatment. Could you elaborate on like what's involved in that kind of treatment cycle? And forgive me, but are we talking about the same immunotherapy concepts in these two studies? Because
Well,
if we are, then I'd like to know why they're working so well.
Yeah, there is some substantial difference. In the Keynote 24 trial, we are talking about a monotherapy with one checkpoint inhibitor, which means it's an infusion that you are getting every 3 weeks without any supportive drugs. In the trial of Dr. Capuzzo, we are talking about a combination of chemotherapy and atezolizumab. However, after the first cycles of combination treatment, the patients continued there with the maintenance treatment with atezolizumab. So this is a little bit the difference. There we are talking about, in principle, about the combination. Here we are talking about a pure monotherapy with a checkpoint inhibitor, also with the favors intolerability.
And could you perhaps comment on what's happening? Why is this becoming a sort of a chronic disease? Because that's a new concept in lung cancer.
Well, I think the principle of an immunotherapy is an indirect principle. So we are enforcing our immune system. We are moving a little bit the brakes of our immune system to control the tumor. And what we have seen, we are not able to eradicate the tumor in all stages, but in some patients, we can achieve a control by this permanent immunotherapy. And this has been the case in their trials, and this we could show at least for a substantial group of patients.
Charles Bankhead, MedPage Today. Have you done any studies, Dr. Reck, to look at people who fared better than others? For example, in the atezo study, the PD-L1 positive group appeared to do better than the others. Have you identified any characteristics in your study that separate good responders from not?
So my trial already was a study in a selected group of patients because we only looked on those patients with a high PD-L1 expression on the tumor cells, which is already a selection criteria for patients with non-small cell lung cancer. We do see this in approximately 30% of the patients. We also looked on the characteristics of those patients who received the 2 years of treatment and compared them to the overall characteristics, and we couldn't find any real differences in all the characteristics. There was only one difference, and this was the histology of squamous cell carcinoma. So in the group of patients who received the 2 years of pembrolizumab, we only had 2 patients with a squamous cell carcinoma. Whether this is predictive or not, I do not know, but these are the only data that we have so far. And besides that, it's really difficult to predict with clinical characteristics the efficacy of an immunotherapy.
Also a question for Dr. Rosell and anyone else who would care to answer. Do you think that there are any differences or advantages, disadvantages with targeting the receptor versus targeting the ligand?
Well, this is an ongoing discussion, and we have the anti-PD-1 and we have the anti-PD-L1 antibodies. So far, we do not have a direct comparison. From the clinical data, at least in lung cancer, it appears that efficacy as well as tolerability seems to be comparable between the two principles of action. Perhaps Dr. Capuzzo also would like to comment on this.
Yeah, we don't have any evidence at the present time that there is any difference between the different agents that we have available and no difference between anti-PD-L1 or anti-PD-1.
Last one. Please, over there.
So as we sit here at the 20th World Congress, 40 years or so after the first, it's incredible to see these data in lung cancer and patients with metastatic disease now living this long and this well. So clearly there are many that aren't benefiting, and we have to figure that out with combinations. But dare I ask, when do we say that we've cured lung cancer? What's the end point? what's the longest you've ever seen a patient out on one of these drugs? And what do you think is the future?
I think we also have to listen to Scott Gettinger because he's reporting 5-year overall survival rates. And this is something we never thought to be possible, I think 5 years ago when we talk about metastatic non-small cell lung cancer. And the question is whether we really can talk about cure of lung cancer after 5 years. This has been our traditional view. If we have a progression-free survival time of 5 years or more, we assume that the patient is cured. However, we still have data when we biopsy the patient that there is viable tumor tissue available in some of these patients. So I just would say we are controlling the tumor. We still have to think about how we manage active treatment. So I think we cannot leave these patients just without any treatment or surveillance. And I think we really have to redefine our definitions, what we do mean by cure in lung cancer. So this is a completely new chapter. We haven't envisaged this 5 years ago, but this is extremely promising for our patients who are diagnosed with this disease.
Maybe.
So I don't know if this is, it's on. So I can say we have done autopsies on a few patients who have been long-term responders to PD-1 or PD-L1 inhibitors. And in a few of those specimens, a few of those autopsies, we've gone to every single tumor site that we knew of, and we went and we sliced very thin, the organs, and we found no evidence of any cancer in some of these patients. So were those patients, was their cancer eradicated, or was it hiding somewhere? But I think that's the best that we have right now to talk to the possibility of cure. Longest I've seen, I have patients, a couple of patients who are out about 9.5 years, and these are patients who already had a few lines of therapy, and when they started their respective PD-1 axis inhibitor, their prognosis was a few months, and here we are 9 years later. So are they cured? I don't know. I mean, from the melanoma literature, we see patients who respond to IL-2 and other immunotherapies that 15 years later come back with disease. So we just need time to tell us this.
I think that today we have, with immunotherapy, data clearly indicating that we have a growing percentage of patients that are alive after 5 years. Historically, that was less than 5%. Today, we have a percentage of patients alive after 5 years that is between 15 and 20%. I think this is the most important message for our patients. The possibility of life is increasing with the new therapies.
Would you accept that non-detected circulating tumor cells would be standard in this case of chronic treatment?
I think this could be one marker to help us. It's difficult to standardize the assessment of circulating tumor cells. It's still a challenge. I think this could be one additional marker. Whether this would be the only marker or whether this would be a sufficient marker, I'm not sure. I think we need some additional work on this.
If there are no more questions, then just thank you so much for your collaboration and your presentation. We're going to move on to the next speaker. Okay, then it's Dr. Gettinger. Please come to the podium. Thank you. Want to keep on immunotherapy as well. And we have this interesting 5-year outcome.
So thank you. It's my pleasure to present to you long-term survival outcome in two registrational trials that established nivolumab as standard salvage therapy for patients with advanced non-small cell lung cancer. This will be the first report of 5-year survival of any randomized trial evaluating PD-1 axis inhibitors in lung cancer. So the Checkmate 017 and 057 trials were similar in that they randomized patients who had previously treated advanced non-small cell lung cancer to nivolumab or to docetaxel. There was no stratification by tumor PD-L1 expression, and the primary endpoint of both trials was overall survival. The Checkmate 017 trial enrolled patients with squamous cell non-small cell lung cancer, and the 057 trial enrolled patients with non-squamous non-small cell lung cancer. So we pooled the results from both trials, and here I present to you the 5-year overall survival data with nivolumab 13.4% and with docetaxel 2.6%. And this is really unprecedented. We wouldn't expect many patients to be out 5 years in this scenario. The benefit was seen in both trials, squamous and non-squamous non-small cell lung cancer. Oops. Progression-free survival was also improved on the nivolumab arm. 5-year progression-free survival rate was 8%. Again, we don't see this in trials. More commonly, we see 0 patients without progression at 5 years, and that's what we saw with the docetaxel arm. The median duration of response was 19.9 months, and at 5 years, 32.2% of the responders were still without progression. So one question that comes up in clinic concerns prognosis in our patients who are doing well with PD-1 axis inhibitors. So, doc, it's been 1 year, 2 years, there's no evidence of active disease. How long is this going to last? So we went back and looked at this in the data. And what we found was that in patients across these 2 trials who did not have progression of their disease at 2 years, 60% of them had not progressed at 5 years, with 82% of these patients being alive. If you made it to 3 years without progression, 78% were without progression at 5 years, and 93% of these patients were alive. And if you made it to 4 years, 88% without progression at 5 years, and all of these patients were still alive. So good news, we did not see any new safety signals with long-term follow-up. In fact, there was only 1 grade 3 or higher toxicity that was related to treatment in the nivolumab arm. This was a grade 3 lipase elevation. There was 1 patient who discontinued nivolumab after 3 years, and this was for a grade 2 rash and eczema that had waxed and waned since starting nivolumab. So in conclusion, these are the first randomized trials to report 5-year outcomes for a PD-1 axis inhibitor in patients with previously treated advanced non-small cell lung cancer. There was a 5-fold increase in 5-year overall survival rate, 13.4% from 2.6%, and a 5-year pooled progression-free survival rate of 8%. Patients without disease progression at 2 and 3 years after starting treatment with nivolumab had a 60% and 78% chance of remaining without progression at 5 years. There were no baseline clinical or tumor characteristics that clearly distinguished long-term survivors receiving nivolumab, and we looked at several such variables. Of note, at 5 years, 10% of nivolumab survivors were off study drug for variable degrees of time, had not progressed, and had not received subsequent therapy. So we clearly see benefit in our patients long after they finish a course of immunotherapy or they stop for some reason, toxicity or so forth. And with 5 years of minimum follow-up, no new safety signals were identified for nivolumab. There was no evidence of late onset grade 3 or 4 select treatment-related adverse events. Thank you.
Thank you so much, Dr. Gettinger. We're going to move to the next speaker, Dr. Bayard. Please go to the podium. We're going to take questions at the end.
So I'd just like to thank the organisers for the opportunity to present this data today on behalf of Lung Cancer Europe, which was looking at the challenges in lung cancer clinical trials from a European perspective. Here are my disclosures. So really the background to why we wanted to do this study is that we know that there are challenges in accessing clinical trials in a lot of European countries, and we do see that there's a bit of an east and west divide when it comes to Europe. And along with that, there's very little known regarding how patients perceive trials or their knowledge around clinical trials. So there's a bit of an unmet need. So the aims were really to gain a better insight into patients' trial experience and from their perspective, and to improve our understanding of their awareness and their attitudes towards clinical trials. And we did this through online surveys with patients and also qualitative interviews with healthcare professionals and some professional advocates as well. So one of the main issues that came out from the more medical side and our professional advocates that we interviewed is really around the idea of the clinical trial criteria, because it was really felt that the final participants sometimes failed to reflect the characteristics of many patients. And from the medical specialists we interviewed, there was not really an agreement between them whether or not there should be a relaxation of inclusion-exclusion criteria. But it's something that really needs to be worked on, because we really need to include more patients that are those that you see in the clinic. When we also looked at patient involvement, we found that there's really a lack of support for patients as research collaborators. And out of all of those we interviewed, one thought possibly in their region a patient may be involved. Their idea behind this lack of involvement really was that they felt there's probably an undervalue of a patient input, that clinical trial protocol development teams are worried, do patients actually have the knowledge to partake in these type of discussions, and also the worry about delays, that if patients feel that something really needs to be changed within a protocol, that this will delay everything for them. But patients can help. And we can't underscore the importance of patient involvement enough. Help with prioritization, help with improved criteria, help with the literature around consenting and information about trials, and also recruitment and retention. And as well, we know from other studies there are differences in what clinicians feel are important, patient-reported outcomes, compared to what patients themselves feel are important. So when we look at our patient study, it was very, very surprising. More than 50% of all those that we surveyed did not know what a clinical trial meant. And even those that felt they understood what a clinical trial was, when you delved in deeper, very few of them actually really truly understood. When we looked at sort of information, one of the things that we found very surprising, I guess, is that patients prioritized the internet and internet searching for information in clinical trials rather than their primary caregiver or their care team. And this is really worrying, because leading on from that, when we looked at did they find the information that they were looking for, only 10% of patients felt that they found out what they were looking for. And even at that, they didn't know if it was the correct information, because there's so much out there. And these are just some of the things that some of the patients said. It was hard to find the information could be hidden, and also the language used was very difficult to understand, because it's not written in a lay-friendly, patient-friendly language. So there's much to be done. And why is it really important to harp on about information? It's because of this. Because the more patients are aware of clinical trials, the more knowledge they have about them, they're more likely to participate in a clinical trial. And that's really important, given that a lot of trials are under recruiting, and then also this can help with retention. And another really key important thing, I think, is that it's not that patients aren't interested in working as collaborators, or that they're not interested in finding out data. From our study, we found that over 75% of patients believed that it was beneficial to work with researchers in the development of the clinical trial protocol. So the take-home messages from our study is really that there is a lack of knowledge and awareness around clinical trials, and this is a really significant barrier to participation and really cannot be undervalued. The existing information, although there's a huge amount of information out there, it's not always accurate, accessible, reliable, or comprehensive. And obviously in Europe we have that added issue in language, because most things are in English, but not all people would have a level of English in which to understand the information. And as well as that, people impacted by lung cancer are interested and should be research collaborators in the clinical trial development process. Thank you.
Thank you so much. We're going to move to the last.
So one thing, I have to make our session starts at 11:30 on the other side of the convention center, where we're going to talk about the 5-year survival. I need to go. If there's any questions, maybe I can answer them now.
If there's any question for that didn't get in.
Okay.
Okay, you're free.
Do you want any repeat treatment data like was shown by the other speaker earlier in frontline where someone's progressed and then you need to treat again? And how have they done?
So you mean in patients that we give them a holiday from treatment for a while?
Yes, and then they recur.
So from our experience in patients, so a real question now is how long do we treat our patients with immunotherapy? And most of the trials have continued until unacceptable toxicity or progression, with the caveat in the pembrolizumab trials, some trials would go to 2 years, and the label, at least in the United States, allows you to stop after 2 years of pembrolizumab. But in our experience, where patients have stopped for some reason and that they've restarted, about half of our patients re-respond. Clearly, if the time until your disease recurs is longer, the higher the chance that you will re-respond. So that's what we've seen in our practice.
Yes, it sounds very similar.
Yeah.
Okay, thank you. Ms. Mitchell, please, now you're going to have this last speaker. It's on establishing a nurse-led follow-up services for patients with resected early-stage lung cancer.
Thank you very much. So my name's Jenny Mitchell. I'm nurse practitioner for thoracic surgery in Oxford, and I set up the nurse practitioner role as a new role after I was appointed in 2011. One of the areas I identified when I came into post that I could improve was our follow-up service. So I have nothing to declare. The backbone of this has been our surgical surveillance program. Prior to my starting the nurse-led clinic, we followed up patients with chest X-ray at 3 monthly intervals for 2 years, and then 6 monthly up to 5 years. We implemented a CT follow-up program, so we do CT, chest, abdomen, and pelvis with contrast, 6 monthly up to 2 years, and then annually up to 5 years. And then I see the patients afterwards to give them the results. We include all patients who have a lung cancer resection where they either don't need adjuvant treatment or they decline adjuvant treatment. The outcomes we've found from this, the patients, it's a very positive experience for our patients. They like the continuity of care. They see the same person all the way through the program. And they have a named person to contact. If they have a problem, they know who to phone. I also act as a first point of contact for all inquiries from other in-hospital clinicians, from our local general practitioners, and from other members of the lung cancer multidisciplinary team. It's also benefited our surgical trainees as they now have time to train with the consultants rather than being solely responsible for seeing patients on our follow-up lists. I don't have lots of numbers, but to give you some idea, in the period of January 2013 to December 17, there were 546 specialist nurse appointments. However, what we found over time was that patients didn't like coming into clinics twice. They had to come once for the CT and then again about a month later to get the results once the CT was reported. So what we did was we set up a telephone clinic. We've set eligibility criteria for our telephone clinic. We spoke to the patients when we were doing this, and what they told us was they only really wanted a phone call if it was going to be positive news. So we only really phone the patients who either have no abnormality on their CT or only minor changes requiring a repeat CT chest in 3 months. And we do get quite a few of those. They're usually for infective changes. Patients also need to be able to communicate adequately, so they need to have a reasonable command of English, be able to hear telephone conversations and have no cognitive impairment. And if they don't meet these criteria, we will see them in a face-to-face clinic instead. The only exceptions for that are, as you can imagine, some of the patients who fit those last 2 categories are the ones who find it most difficult to come into the hospital as they're elderly and have other comorbidities. So in certain circumstances, we will talk to a relative instead, but we always agree that in advance. So the telephone clinic, this has increased the number of follow-up slots available to our post-operative patients. and reduce the time that all of our patients wait for their clinic appointments, whether they're coming to the face-to-face clinic or the telephone clinic. Particularly for our patients with abnormal CT results, it's meant that we've been able to see them a lot sooner. And our patients really like it. They have continuity of care. The person who's calling them is the same nurse they've seen in the clinic. They've saved the journey to hospital. And to give you some idea of the numbers for this, in the first 12 months, there were 254 appointments in the telephone clinic, and in the second year, that increased to 315. So that was 315 visits to the hospital that were saved. And this is what our follow-up program looks like now. We see everybody in clinic for their first follow-up appointment. This is the point they're given their pathology results from their surgery, and we assess them and make sure that they're recovering okay from their operation. If they need adjuvant treatment, they're referred to the oncologist, and if they have that, they are followed up by oncology, not by us. And everyone else comes into our follow-up program. Once patients have had their CT scans, it's me who reviews the results, and I allocate patients to the appropriate clinic. If there's any abnormality on the CT that we're concerned about, I will take that to our lung cancer multidisciplinary team meeting. We will discuss it there, and I take responsibility for actioning the outcomes from that meeting. And we now have a way of communicating that. It's all documented on our electronic record system, so everyone can see what's happening with these patients. So this is obviously outside your standard nursing practice. To do this, you need advanced level training. Most UK universities offer master's level courses in advanced nursing practice. So you do history taking, clinical examination, diagnostic reasoning, and non-medical prescribing as part of this. Imaging interpretation is obviously very important in this specific area, and you need a very good knowledge of lung cancer pathology and prognosis. In the UK, to request any radiation imaging, you need to undertake a specific radiation protection training, and you also need an approved radiology requesting protocol. This was the hardest bit of setting this clinic up. It took quite a long time, and I needed the thoracic radiologists very much on site to get that support, but I am now able to request CTs. Throughout all of this, the support of the multidisciplinary team is essential in making it work. So, in conclusion, nurse-led follow-up after lung cancer resection is an effective way of ensuring high-quality care for this group of patients. The specialist nurse is able to provide continuity of care and ensure that all imaging results are followed up appropriately. And the role requires the support of the multidisciplinary lung cancer team to work effectively across all elements of the patient pathway. This model of care can also be used for patients having other modalities of treatment, and there are lots of good examples of that within our nursing forum. Thank you.
Thank you so much. So now both papers are open for questions, discussion, comments. Yes, please, over there. Okay, go ahead.
Shreya from Medway News. Question each for both of you, if that's okay. Dr. Baird, did you see any differences by country?
That was probably a little bit of one of our limitations, in that although we had nearly 300 respondents, there were some countries which were more representative. So Poland and Italy had the highest number of responders at about 50 per country, but somewhere like the UK had only 9 responses. So it was quite varied across, but one of the things, I guess, is because that sometimes it's hard to get a lot of responses within each EU country or each European country, so we have to use it in terms of an overview, and we have given that back to our members, and they've agreed that a lot of what we found in our study is kind of what's reflected that they're seeing regionally as well, but it is a limitation that we just don't have the numbers to break it down quite specifically as that.
Thank you. And Dr. Mitchell, how long is the average telephone call? And also a comment on if you set up a face-to-face appointment, the patient knows there's possibly bad news coming. Does that affect their anxiety levels?
So telephone calls sort of average about 10 to 15 minutes. What we find even in our face-to-face clinics is the patients who are sometime after their surgery, they don't want to hang around. They come in, they want you to tell them their CT is all right, and they go. I do go through, respiratory status and things like that with them on the phone. So yeah, about 10 to 15 minutes. The issue you mentioned about calling them into a face-to-face clinic is our biggest concern, and we have not come up with a way around this. What we do is we make sure that we call them into a clinic very soon. So they will be discussed at our MDT meeting, and they will come to the next clinic. So they will wait normally, and we don't contact them till we've discussed them at MDT, because some of the patients we take, we then can be more reassuring, so we can put them in a telephone clinic. But we try to make sure they wait less than a week to come. But it is a problem, and I don't really have an answer. I am always a bit vague about what clinic they will go into, but most of them can work it out.
Okay, and then last question before we close this session.
One for each speaker. For Dr. Bard, clinical trial access and getting patients on trials is so important. I'm wondering, in everything you've done, the role of patient advocates in all of this, through your research, have you found that they can help with the issues of trust and information to patients throughout the world?
Yeah, we have found as part of this survey that about 1 in every 3 patients that looked for information did get it from either another patient or a patient organisation. And those other patients that are trying to get information from other patients, those patients are tending to get their information from patient advocacy organisations. But I think as advocacy organisations, there is a bit of fragmentation, and I think we need to work better together to have concrete, harmonised messages and information so that it can be a little bit more sort of broad-based.
There could even be a role for the IASLC perhaps in this whole process.
Yeah, absolutely. I mean, that would be really great, because even some simple terms, it was hard for them to understand. Even accessibility of websites, trying to click and click and click, and and it gets very frustrating for patients and for caregivers. And the language can be so technical that then there's a tendency to go, oh, I'm never going to find what I need, so that just give up. So it's really very important.
Thanks. And Virginia, in the United States where I work, as a chair of a department, access is the #1 topic at every meeting I go to, getting patients in and seen on time. So I think your program is wonderful. So just thinking of what the barriers might be, for example, in other countries, like to export this to the U.S., I'm thinking one, reimbursement issues perhaps, but the other is just there's a shortage of nurse practitioners. I don't know if that's true where you are, but we cannot find enough in New Haven of people, even though we have many offered jobs.
We do, and in Oxford it's a particular problem because it's an expensive place to live, and we're not far from London. If you go into London, you get paid more. So it is an ongoing problem, but I think all we can do is keep promoting it. It's a very rewarding job, I have to say, so we can just keep promoting that. In terms of reimbursement, obviously in the UK we have where the hospital is paid by clinical commissioning. We are paid less for the telephone calls than we are for the face-to-face calls, which is how we were able to increase the capacity. But obviously it comes at less cost. But then I'm not taking up space. I sit at my desk with a headset on doing this. So. Thank you.
Okay, thank you so much, everyone, for attending. Thank you so much for the speakers and attending your questions. Okay, bye-bye. Have a nice day.